the next one we're going to talk about is diabetes and metabolic syndrome. A lot of people have heard of diabetes pretty much at this point. At least they may have known people that maybe even talked about it a good bit this semester. But right, diabetes is a major problem. More than 100 million Americans have diabetes or are pre-diabetics, and we'll see why that number is so high in a little bit. And it is a very expensive industry. There's a lot of legal drama in this space, and these kind of tie together because people who are obese, which affects both your diabetic response and your metabolic pathology, those are kind of correlated with each other. So we put these in the same lectures. But yeah, we have an obesity epidemic in America that's really taken off in even the past few years. And so as healthcare providers, I guess if you go into a certain type of nursing, that is, you can avoid this. But generally speaking, there's a lot of nurses that have to interact with people with metabolic diseases and diabetes. So it's an important thing to go over. You can strategically avoid it. There's ways. Become like a, I don't know, or a kid nurse, child, like babies. Those don't usually have obesity. Well, they can have type 1 diabetes. Yeah. So I don't know. I guess there's some way that you can avoid diabetes if you really tried. But all right. So the first thing we kind of talk about with this is just how we look at obesity. There is a gold standard technical way of doing it where you do these body scans, or there's a way that you can send electrical pulses through people's bodies, and then electricity moves slower through fat than through water, and so you can measure the response up and down the body of how electricity moves. That'll get you very accurate body fat content measurements, but the quick and dirty way of doing it is with the BMI, where you have it's just an index where you look at how much a person weighs compared to how tall they are, and if they are a boy or a girl, and then it'll give you how obese they are at a generalized level. The problem with that is that if you ever look up how NFL athletes, these prime or professional athletes that are the pinnacle of health and working out and stuff like that, and have zero body fat, they are oftentimes considered obese in these scales because they just have so much muscle mass that it doesn't account for your actual muscle mass. So they can be extremely misleading, but I guess they are used in the clinic as a quick and dirty just measurement. But they're not perfect. It can be very misleading. Regardless, people who do check underneath the obese or overweight categories, they have a higher propensity of having metabolic syndromes, where and this is kind of some breakdown of this. We have a lot of people in Louisiana are considered obese. We're one of the worst states per usual. Good job, LA. Maybe we should change the BMI index, really. Add a third category.
I think we just and big bones.
I agree. I don't.
It's unreliable.
Yeah, the thing is that and I'm tinkering right on the edge. Yeah, I was running I was training for half marathons, and I was and at my weight I was running half marathons, and I was still considered obese by the scale, and I was dang. Yeah, so it's not a good measure. Now I will say this though.
I'm obese on the scale.
So
on the scale, I'm obese.
the thing is that when you take a step back on the individual level, it's kind of crap, right? But when you take a step back, I think like people have done correlatory studies between the BMI and actual body fat, um, obesity level readings, and the vast majority of people do correspond to BMI measurements. But it's something. These aren't the right numbers, but it's equivalent to being like 60 to 70% of the population does correspond to BMI obesity classifications, but 30% don't. And so if you're in that 30% category, then like yeah, it's just not applicable to you. Like, but for the most part, I think the reason why it's still being taught and practiced in clinics as like a number you at least look at is because most of the population does, at least in America, especially in Louisiana, I bet. It does correspond to obesity. So that's what. So it's like it's not useless, I would say, but it's just not reliable. But it's expensive to get those scans and like. Well, it's actually not that
This
expensive.
is why little girls are growing up their food. And believe me,
Anorexic. Yeah.
it's not fun. I remember I was in 7th grade and my pediatrician gave me like a graph and he was like, "You're not obese, but you're overweight. And look, here's the curve."
Yeah, we need to very much avoid that kind of stuff because I think like when you just teach it in elementary schools, yeah, that's not good. When you teach all these like little nuanced caveats, like I'm saying now, it's like okay, that's probably good, but yeah, telling some little 11-year-old girl she's obese when she's probably healthy, especially in like those preteen, you're like right before puberty, you're supposed to put on a whole bunch of weight because your body's like prepping for the vast amount of metabolism that you're about to go through before doing growth spurts. So like preteens a lot of time gain a ton of weight and then they just burn it whenever they go through their growth spurt. It's like a normal human being thing, and it's probably you're stunting. You can do things like stunting growth or cause long-term damage if you encourage that behavior.
I
So,
stopped my pediatrician after that.
uh-huh.
Because how dare you show me a
Oh, your
curve
pediatrician said that? I thought you said it was a teacher.
No,
Oh.
my pediatrician.
Yeah.
He showed me like on the curve. He was like, "Yeah, you're not technically obese, but you're overweight, and here's the curve."
Yeah, fuck that guy. Whatever.
He's retired now.
Well, whatever.
That's where he should.
Probably for the best. Okay. Where are we at? So having, so there's a whole bunch of risk factors associated with metabolic syndromes. That's increased high blood pressure, right? That the reason why is because of things like the deposition of plaques and atherosclerosis, right? We talked about a lot. High blood glucose, we'll talk about today. Excessive central and visceral adiposity. That's what it is. Right, you have fat around your midsection and you have excessive fat around your midsection and there you go. And then you have high triglyceride levels, obviously, and low HDL levels, low HDL cholesterols. That one's where you the LDLs is what measures kind of how much cholesterol. The LDL to HDL ratio is what measures how much cholesterol you have, and cholesterol correlates with fat to an appreciable extent. So these are all kind of signs of having metabolic syndrome. We also have this, right, so these people have increased risks of all the metabolic diseases that you might think of, right? Coronary heart disease, atherosclerosis, type 2 diabetes, heart attacks, kidney disease, stroke. We've all talked about these pretty extensively. So when looking at the blood glucose, your blood glucose is regulated, right? It needs to be. Whenever you have, right, because we go through periods of eating and not eating, especially sleeping where you're not eating for like 8 to 10 hours, your body has an extreme selective pressure to regulate glucose because you need to go through periods of where you have high glucose in your blood, but then whenever it decreases because you're not eating, you need to release your glycogen stores and cleave off those glucoses from glycogen and release that into the blood. And then if that even gets depleted, you then need to fall back on your ketone reserves and your fat deposits. Your basic biochemistry here. And so one of the main ways that you regulate both the release of all of that and the usage of blood glucose is this dynamic between two hormones, insulin and glucagon. Have y'all heard of glucagon before? I imagine y'all have all heard of insulin. I think we've all talked about insulin. Do y'all take like an endocrinology at all? Oh. Okay, good. We just got like an hour of it. Right. So right. Well, then y'all know this pretty well. Then so insulin gets released whenever you consume glucose. It is released from the. Does it say on here? Yeah. Oh yeah, no, right there. The beta cells of the pancreas. Yeah. Okay. So I see this flows right. So you consume blood glucose, right? You secrete insulin from the beta cells of the pancreas. Those then bind to insulin receptors on the tissues, and then those insulin receptors will cause cellular changes to where you import glucose into the cells, and then because glucose is then imported into the cells, you go through glycolysis and all the metabolism that we talk about. Now, if those blood glucose levels go, so that's what happens when the blood glucose levels go high, right? You have glucose in your bloodstream. If they go too low, you have glucagon release from the pancreas as well. Those then will bind to cells mostly in your liver, and then that will stimulate the release, because your liver is the main way that you secrete ketone bodies and glycogen regulation, and so it'll increase the amount of glucose. So this is how you deal with fluctuations of eating and not eating throughout the day, right? Now, the problem becomes whenever, sorry. Well, yeah, there's a problem with hypoglycemia and hyperglycemia. Hypoglycemia is where it goes too low, and you have a physiological response to that, right? You have increased heart rate, trembling, nervousness, sweating, anxiety. And if it gets really low, you can just straight up die. That's just like not having enough energy in your body. And there's also hyperglycemia, which is a major problem in America, where you have too much glucose circulating, and because of that, there's hydration shell problems, so you get really, really thirsty. There's also regulatory stuff with your kidneys, to where you are frequent urination, and then there is you kind of rely on always having high amounts of glucose, so whenever it like shifts that equilibrium up. This is just like the adaptation lectures that we talked about at the very beginning of the lecture. If you are always eating high amounts of energy, when you're eating a dozen donuts every single day, your body's going to think that's the baseline, right? And so whenever you're in, and this is like what diabetes is like your insulin only gets released if it reaches that maximum threshold. So like people who are obese, they have to like maintain that obesity, kind of, is like a weird way of looking at it. Or they have like a hormonal drive to maintain that obesity, and so they're always eating stuff. I have a friend who's gone through a weight loss journey since then, but like 10 years ago, or 5 to 10 years ago, he would bring like an entire tub. Like he was like 450 pounds, and so morbidly obese, and you bring an entire tub of like pasta. That was like this big, and you have to eat that. So all this saying is that there's like and it was like 5 or 6 cups of pasta. And so all I'm saying is that to maintain that like levels of obesity, you have to keep consuming those high amounts of calories, right? And so you have this physiological response because of that. Forget those questions. All right, so right, in lockstep with that same story, though, right? If you increase the amount of calories you consume, the amount of glucose you have in your body, your body's only going to release insulin to absorb that glucose accordingly. And so what happens is that whenever you have these high levels of glucose, you can have you have insulin release in your body become desensitized to insulin, and that's what these type 2 diabetics go through, right? So insulin allows your body to use these glucose, right? Liver can make glucose, gluconeogenesis if you're in starved states. Right, the other gluconeogenesis is create glucose, exactly. Neo as well, create new glucose, right? So it's a way of there's a lot of overlap between the reverse of glycolysis and gluconeogenesis. So you can kind of think about it that way, conceptually at least. You go from pyruvate to glucose, or carbon dioxide even to glucose. Regardless, insulin promotes storage of nutrients in the forms of glycogen, lipids, and proteins. It inhibits lipolysis, which is the beta oxidation you might have heard of, or fatty acid oxidation, where it's just where you break down fats. And so what it's saying is it's an enzyme that just says use glucose and store it, right? Because high levels of glucose are available. And then obviously that's going to be, we'll see what it's related to. So the main signaling that happens, and is that, and this is a Pathophysiology study actually, is insulin binds to these insulin receptors. That's like what they're called. And these insulin receptors have this phosphorylation motifs in the cytoplasmic tail of the cell. So this is looking at the cellular level. What is your response to insulin? And so what happens is that there's phosphorylation of the cytoplasmic tails of these insulin receptors, and it'll bind a protein called phosphoinositol 3 kinase. Phosphoinositol 3 kinase is a kinase, right? So it's going to phosphorylate downstream lipids on the inner leaflet of the plasma membrane that eventually lead to activation of another kinase called AKT, which then phosphorylate the regulators of these GLUT4 containing vesicles. And long story short, when you have insulin around, it integrates these glucose transporters onto the cell, and then it allows glucose to be uptaken by the cell in response to glucose. So hint, hint, nudge, nudge, I guess. Don't forget to do your bonus questions. It closes on Sunday of this week. I know we didn't do one last week, so I think I just gave y'all I'm just going to give y'all the bonus points for that because I just forgot to post the question. But yeah, don't forget to do your bonus quizzes. I guess that was a bad time to say that, right? When 2 people leave the room, but whatever.
I checked last night to make sure I didn't miss it.
Yeah, you're good. I'm keeping track of it in my head. I'm pretty much, no one really misses these bonus questions. They're pretty easy, so it's like I pretty much just add 2 points to everyone's quiz. But I still check before the test, so make sure to just do it. All right, anyway, so we have insulin resistance, right? So begins before patients are diagnosed with type 2 diabetes, right? So that's when you're fully progressed into the stage. Nowadays, they have all these classifications with diabetes and your lack of a response to like pre-diabetic, pre-diabetic, I think is even becoming a thing. So it's just you have insulin resistance that develops, especially when type 2, right? Because type 1 has more of a genetic component. But so clinically, to establish if someone is insulin resistant, they're unlikely Clinically unlikely to test for insulin resistance specifically, but if patients has a high blood sugar. Yeah, so you're looking at high blood sugar levels, high triglyceride, and high LDL cholesterol with low HDL, right? So it's the proportion just thrown off. Right. What you're really trying to assess is the metabolic conditioning of a person's body. The treatment goal is to become more insulin sensitive, right? And so because your body is good at adapting, right, the opposite is also true. If you eat so many calories to where your body's shifted the hormonal equilibrium to such a high level to where you have insulin resistance, you can actually shift that back down if you just starve yourself to an appreciable manner. Like insofar as consuming less calories than your body needs, not like socially starving like anorexia. I'm not trying to encourage anorexia here, I guess. But your body can adapt to lower amounts of caloric restriction, and so our caloric intake, which is caloric restriction, and then you can shift that equilibrium back. So long story short, you can, to a certain degree, you can reverse type 2 diabetes, especially if you're pre-diabetic or pre-diabetic, by doing things like working out, which utilizes the glucose available, and then it makes you it becomes more sensitive to insulin, or eating less calories. So physical activity, avoiding high blood glucose. Yeah, eating also healthier stuff, even though it might be the same amount, like by mass. But if you shift from eating donuts to eating vegetables, it'll be better for you as far as insulin resistance goes. And then smaller things like reducing stress, getting enough sleep. Getting enough sleep is good because, right, your body fasts more, and so you become less. You have these extenuated periods where you're not consuming glucose, so it's like getting sleep is good. So diabetes has a higher degree within men. There's a relationship between insulin, glucagon, and testosterone levels. We won't go into it, but it's slightly increased in men compared to women. And then also, that's like a biological reason, mostly probably. There might be some social reasons as well, but these are all. But the ones on the right, where it's affecting non-Hispanic white people more so than non-Hispanic black people or Hispanic people, that's probably more socioeconomic reasons of like people who don't have money typically spend money on poor food, right? Or poor nutrition food. And so they'll eat things like Taco Bell or they'll like where that's like the extent of their diet, and then they are other fast food or donuts or whatever, and then they will because of their poor diet they'll have diabetes. Now, so yeah, there's probably social because biologically speaking, there's not that much different between Hispanics and non-Hispanic black people compared to white people. So it's probably socioeconomic, especially in America. These are American statistics. So yeah, diabetes, the body's ability to produce or respond to the hormone insulin is impaired, resulting in abnormal metabolism of carbohydrates and elevated levels of glucose in the body. Right, you're not responding to insulin, and so you're not pumping that blood glucose into your tissues. So there's a buildup of glucose in your blood, and you're not utilizing glucose. You're not responding to it. A lot of people have it in Louisiana, obviously. A lot of people have it in America. A lot of people have it worldwide. It's a major problem. Pre-diabetics occur when the pancreas does not make enough insulin to maintain normal glucose levels, right? So, right, we got two different types, right? We have this type 1 and type 2. You probably know about this. Type 1 is where you have a genetic component, while type 2 is where you have, it's more of a adaptive response to poor maintenance of your metabolic levels. There's environmental factors for type 1 that can contribute. but both result in a poor ability to regulate your glucose levels. Type 1, though, is typically you either have a problem with the insulin receptor or you have a problem with releasing insulin from the pancreas, while type 2 is usually you have desensitization of the cellular response. So these are problems with the PI3K, AKT pathway and things of that sort. Yeah, it used to be called adult onset, but kids are getting type 2 diabetes. It's kind of a shame. It's like the diet of children is so bad so quickly that children get this, and that's just probably bad exposure to good nutritional practices really early on, probably encouraged by parents. When the parents have bad nutrition practices, it usually rubs off on the kids, right? It's not shocking. So this is a good little picture about what's going on. So here's your healthy on the left. Here's your healthy person, right? They're going to release glucose either from their diet or their glycogen. It's going to, your blood glucose levels are going to go up. You have insulin release from the beta cells, the pancreas. They bind to receptors, trigger the PI3K, AKT pathway, and absorb it, use it, perfectly fine, everything's great. With type 1 diabetics, usually what's going on is that you are not sensing that glucose and making insulin accordingly, or you have a problem with the receptors to where you're not no insulin to activate. So you don't have insulin to activate these receptors, so you don't have absorption. So you have a buildup of glucose. You can kind of see around the circles made by the arrows. There's more glucose compared to the healthy person, and there's also no insulin. So what's great here is, though, and you'll see some pretty striking pictures later on in the lecture, right? Insulin is not glycosylated. It's not a glycoprotein. And so what can happen is that you can make these proteins in bacterial cells recombinant. You might have heard of recombinant insulin levels, and then isolate the protein and just give it as a drug to diabetics, right? And so that's what these insulin shots are. And that will increase the amount of insulin. So if you have a problem with the releasing of insulin from the beta cells, that can fix the issues, right? Type 2 diabetics is that your beta cells are probably functioning perfectly fine, but you have so much insulin that's been consistently released that your receptors are not responding to the levels they've been selected against. So you have less glucose uptake. So you have tons of insulin in your bloodstream, tons of glucose in your blood, but there's just no physiological response, right? So there are symptoms associated with all diabetics. You kind of see this list: frequent urination, excessive thirst, increased hunger, weight loss, tiredness, lack of interest in concentration. The weight loss is the one thing you might be confused about. What you can kind of think about this as is that your body is not using the glucose that is available to it, so it has to get its energy from somewhere. So it burns fats as ketone bodies, and so you lose actual fat levels in your body. So it's kind of a weird way of thinking about it, because typically we think of diabetics as being obese. So that can fluctuate between type 1 and type 2, whether or not you have weight loss. The rest of it kind of makes sense, though. Lack of interest in concentration, numbness in the hands or feet. That's a crazy symptom there. Blurred vision, frequent infections, and slow healing wounds. Yeah, just if you can't use glucose, your whole body goes crazy, right? Your immune system and your neurons and everything, right? So this is a crazy picture. This is a picture taken like 100 years ago, I think, like a while ago, and back when like insulin was still being researched to see if it would even work. They like barely knew about it. So they took this girl and then they gave her, she's like, you can see the severe amounts of weight loss. She has type 1 diabetes, severe amounts of weight loss. And then they just injected her with recombinant insulin and monitored like however many years later or months later, and she had great responses. She started utilizing the glucose that was available to her and not burning all the fat, and had a great physiological response to things. So insulin can have a drastic effect. That's why having insulin available to people who are diabetic is really important, especially type 1. And so there's just all this drama like a couple of years ago with like legislation about price gouging of insulin. Did y'all follow that at all? There's like a congressional hearings and regulation of insulin.
Oh yeah, it was like over $1,000.
It was like $1,500,
It's ridiculous,
right?
and it's dirt cheap to make, relatively speaking, drug wise. It's one of the cheapest. They had some of the highest margins in drug regulation, and so they were.
And now it's hard for diabetics to get insulin now, isn't it?
I think it's more so the
Ozempic,
the
and the blue light. Mm-hmm.
Oh yeah. So that's another problem that we're probably going to see in like the next 5 years, that Ozempic thing. Because what Ozempic is just insulin for the most part, I think. And so you have to think like if you have if you're taking injections of insulin, what does that do? We've seen that.
Ozempic is not insulin.
What?
I said Ozempic is not like insulin.
Oh, what is it then?
It's like it's trying to help your body create
So it's just a stimulator of the beta cells then, or something like that.
kind of like that.
Yeah. So, but insulin levels definitely go up with Ozempic, though, right? That's what I've heard from a couple different sources.
But it is called like a balance.
Okay. Yeah, but I think it eventually releases. You have higher insulin levels. But regardless, we're gonna have probably with this like Ozempic craze or whatever you want to call it. There's probably gonna be some downstream diabetes effects to some people, but maybe not. I don't know. I'm speculating. To where it's like what we're doing, I don't know, but it does cause weight loss, I guess. So I don't know. Might be a challenge that future generations are going to have to face. Regardless, insulin is a great drug for people who are ectopic insulin is a great drug for people who are type 1 diabetics. Long story short. Oh, there you go. 1922 to treat type 1 diabetes. Oh, and then there's I have this like article on Moodle about that if you want to read, but not testable, not tested. Okay, so we also have these metabolic syndromes, right? So we have these adipose tissues, and that's all your fat tissues. Really great for storing highly calorically dense molecules of fat. And you have two different types. You have white and brown, with brown adipose tissue being more metabolically active, while white adipose tissue is mostly a storage mechanism. You can mobilize these fats in a few different ways whenever you need them. The first being albumins, the second being other proteins because fats are lipids, they don't solubilize in water, so you need something attached to them, an emulsifier to mobilize them. But once they're mobilized, your body can metabolize them, go through beta oxidation. If you're a fatty acid, there's cholesterol metabolism as well. And those are the two main lipids, right? But yeah, your body stores these in two different ways. You have the subcutaneous, which is like, right, you'll understand anatomy, I guess. Right, you have skin, and then fat, and then muscle. That dude who I was talking about earlier, who was like 450 pounds or whatever, and then now he's like 190 or something. He's like lost a ton of weight. But the thing is that layer of fat was so thick that, and you see this with like morbidly obese people, that layer of fat was so thick that it separated the skin from the muscle. And so like after he lost all this weight, that those connections don't reform, and so you have like saggy skin kind of, and there's ways to like surgically like tighten everything back up and stuff.
That's what my boyfriend has right now. He was like 250, now he's like 180, and so all in his stomach he just has like a whole layer.
Yeah. Yeah, this dude, one of my friend, he went to Turkey like a couple months ago to have that surgery.
Really?
Yeah, they it's cheaper to do. Yeah, you gotta like see Istanbul and Hagia Sophia and all that. It was cool. I was jealous. I want to go see Hagia Sophia one day. Yeah, there's all kinds of surgeries. Medicine's just so much cheaper in Turkey.
My friend was contemplating going to Turkey. I know this guy does really good in Dallas. He does really good ethnic nail stuff.
Oh, okay, that's great to take note. Um, all right, we got here.
Dr. Miami.
He's booked up. And Dr. John Money, that's what I would go to if I want to get some lipo.
All
I
right,
would pay $16,000.
reach. Yeah, I get it. Anyway, speaking of lipo, we have um, visceral and subcutaneous fat, right? So visceral fat is all these fat that lipo would not remove insofar as it's associated with organs, right? So I have no idea if they remove that on actual whatever. So you have fat that's like subcutaneous and in that fat layer below your skin, and then there's the fat that's just associated with organs, and so you usually with people who are morbidly obese, they have higher levels of both, but a lot of it associates with the subcutaneous versions of it. So adipose cells, these adipocytes, you can kind of see them in this picture. Normally they should be in a healthy metabolically healthy range. They are about this size, but you can see they balloon up whenever you have high levels of fat. So people who are morbidly obese, they do not have more fat cells necessarily, just the fat cells are bigger and they store more fat in those cells. Light does not move through fat really at all, and so in these images, where you see white, there is fat, and where you see not white and you see stain there, that's like the rest of the cells or tissues. It's probably the space in between the adipocytes, and things like macrophages, right? So, right, as you may or may not know, macrophages can regulate your fat metabolism and are pro-inflammatory when they do, and that's why people who are morbidly obese usually have high inflammatory levels at baseline.
Babies are more brown.
Yeah, I think babies have more brown than white. Admittedly though, I get gray and white brain matter confused with brown and white fat matter. So I don't know.
I think babies, it's the brown adipose tissue because you're like born with it. Like helps regulate your body.
Yeah, because they're more metabolically active. If you have more metabolism, release more energy. So that would make sense. Yeah, that's a good way of remembering it. Yes. So when you have high amounts of fat, you usually have a dysregulated immune system as well. So with diabetes, you can look at first of all your sugar levels, and then there's kind of different ranges that y'all won't have to memorize or anything about what's. You can also look at insulin levels, and so getting a ratio of insulin levels and sugar levels, you can kind of determine if someone's diabetic, type 1 or type 2, pre-diabetic, and all the necessary stuff. But y'all won't need to know that for these tests at all. But there's good molecular ways of diagnosing diabetes. As far as assessing it, you can regularly test for acylated hemoglobin, which you might have heard as, like glycolated hemoglobin, which you might have heard as HbA1c or just A1c on all the little TV commercials. And what that is that because there's so much glucose around, in your blood, your red blood cells will absorb some of that glucose and link it to your hemoglobin itself. Sorry, no. The hemoglobin gets released and it will from the red blood cells, and then it will bind to the free glucose that is in the bloodstream, and you can measure how much glycosylated or how much glucose is on these hemoglobin molecules, because normally there shouldn't be a ton. There shouldn't be really any because you regulate glucose levels well. So it's a way of like monitoring that. So this is what people are measuring whenever they are measuring how like what their blood sugar is. So it's a marker for average blood glucose levels of the previous months. Yeah. So it's a good way of kind of monitoring how well your response is. So usually when people are diabetic, they're trying to bring down their A1C levels. All right, so there's a whole bunch of things associated with the diabetes nerve disorders. Diabetic neuropathy is damage to the nerves of the body, and this can get really, really bad. So there's peripheral effects, the nerves in the toes, feet, legs, hands, and arms. So this is literally you just kind of lose nerve, you lose sensation in your nerves and your extremities. And there can be tingling, burning, deep pain, weakness. This is something that confused me whenever I learned this, because I'm just like, why do people have like all these peripheral circulation problems? But yeah, your nerves just like lose that sensation. So it affects the autonomic nerves that help regulate digestive, bowel, bladder, heart, and sexual function. And you get these tingling in the arms, and you often lose feeling to start your toes, and it results in stuff like this, which are disgusting. It's very much problematic, because what's happening here is that you have some injury, and then your body doesn't feel that injury, and so there is like these ulcers that like will occur, and so because you don't feel it though, your body doesn't really respond to it, doesn't heal it up that well, and it just gets worse and worse. Can get infected really easily. You have a propensity of infections already starting with if you're diabetic, and you get these foot ulcers, and sometimes it gets so bad that you just have to cut off the whole thing, and so you have these amputations that occur subsequently to that. The most serious consequence of neuropathy occurs in the legs and feet, pose a risk of ulcers, and usually severe cases amputation. And that's a lot of the amputations in the U.S. Crazy stuff. These are like this is really bad diabetes though. This is like, it's not something that if you're like pre-diabetic or just that it happens that much. You also have this retinopathies. So what happens here is that you get these little, see these like little these little dots in this picture here. Can you see it? I don't know. You might be able to see. Oh yeah, you can see them. You might be able to see them better on your computer. I don't know. But what'll happen is that those little dots will appear on these. This is just imaging of the back of your eye, right? And oh yeah, you can kind of see it here, right? You're imaging back here, and then it's taking a picture of this back wall, and you get these little dots appear. And then also there's vascularization that's abnormal as well. And these obstruct the capillaries from very tiny blood clots. And so what you can do is come in with either a laser or oh, here we go. Yeah, photocoagulation is where you come in with a laser, and then you can remove these little spots, and then or you can remove them with really fine needles. But so both these are kind of doing the same thing, just in two different ways. And then you you suction it up with a vacuum as well. Crazy surgeries. And then we also talked about in the kidney disease lecture that diabetics have higher amounts of kidney disease, and so it's also applicable here. The kidney glomeruli become damaged and they leak protein into the urine. It leads to kidney failure, and protein in the urine is an important marker for kidney damage. And there's a whole bunch of things associated with kidney failure. And this is kind of the percentage of people of what causes kidney failure, and you can see a large proportion of that. The major proportion is diabetes. The leading cause of end-stage renal disease occurs about 20 to 40% of patients, and you just need to fix these things. Start regulating your diet, start regulating your exercise, glycemic control, and make sure you're eating the correct amount of foods to where you're not getting a whole bunch of blood glucose and glucose in your diet. Eat vegetables instead of donuts, I guess is what I'm saying. And if the kidney fails, dialysis is required to remove these metabolic waste from the blood. So everything that's applicable with that kidney disease lecture is also applicable with really bad diabetics as well. Getting a kidney transplant might be needed as well. And then there's also a correlation between cardiovascular disease and diabetes as far as they're both metabolic problems. We've talked about this a good bit with regard to cardiovascular disease, so there's not a ton of new stuff here. This is kind of just associations with cardiovascular disease and diabetes, and associated with HDLs and high triglycerides. And you kind of get why now, right? Blocks that circulation. This is important for the last lecture, right? We talked about acidosis last lecture, and one of the things that causes it is diabetes. That was one of the bolded ones that y'all have to memorize for the test. This is kind of the reason why, right? So you have diabetic ketoacidosis. Do y'all know what ketoacidosis is compared to acidosis? Yeah, the ketone bodies that form. So your ketones are ketone bodies are these the functional group of a ketone, right? It's just a internal carbonyl on a carbon chain. So there's a class of molecules called ketone bodies that contain these ketone functional groups, and they are made because when you metabolize, you can metabolize fats and then release ketone bodies into the bloodstream for your brain to actually metabolize. Your brain.
Isn't this the one that gives...
What?
Isn't ketoacidosis the one that gives you like a fruity breath?
Yeah, like a sweet kind of. Yes. So what will happen though is that these ketone bodies get released to the bloodstream. Your brain can use them as metabolism along with glucose. And the problem is that whenever you're doing this a ton, whenever you're metabolizing so much fat that you have a whole bunch of ketones released, these turns into acids. And so whenever you have high amounts of fats being metabolized, because you're not using glucose as an energy source, you're only using fats, you make a whole bunch of ketone bodies. Your ketone bodies then act as acids and then increase the amount of acid in your blood. And then you get acidosis from it. So this is one of whenever diabetes gets bad, so you get this ketoacidosis. So in an acute version, this can be absolutely life-threatening. It's these ketones, when they build up to high levels, they can be very toxic and poisonous. Metabolically, they are normal. like at low levels, like it is normally, they can be like fine for you. It's just whenever they build up to high levels, it's when it becomes bad, and it can have an acute condition. Develops rapidly within 24 hours, and you get polydipsia, polyuria, so you get really thirsty and you urinate a lot. Volume depletion because of that, and then hypotension and increased heart rate because of the loss of the physiological adaptation because of the loss of fluids, right? Treatment would be insulin shots, fluid electrolyte replacement, and you treat whatever's causing that insofar as lifestyle changes, eating right, working out. We also have this HHS, this hyperosmolar hyperglycemic state. Hyperglycemia is where you have a lot of glucose around. Glucose transporter in cells is limited due to insulin resistance. And so because of this, you have more molecules in your bloodstream, and so you have a hyperosmolarity as well. And glucose, because you have more particulates in the blood, and glucose is filtered and excreted additional, and fluid is lost and concentrated in the plasma, right? So importantly here is that you drink more water. And what will happen is this will not happen without significant, this will happen without significant ketoacidosis. So those don't correlate. More often in type 2 diabetics, the underlying infection in older individuals, and this is where you have lower circulating glucose, serum osmolarity, dehydration, and the treatment's a lot of the same stuff, right? Insulin replacement, fluid electrolyte replacement, treatment underlying condition. As far as diabetics, there's some good stuff. Y'all talked about this in Farm. I don't really need to go over this then. Yeah. Again, and y'all won't be tested on drugs. Just continue monitoring glucose and then take treatments accordingly. There's also ways to help with metabolic syndromes. These are surgeries. My friend has also got this surgery done, where you can remove part of your stomach, and so that'll reduce the amount of nutrition you absorb through your stomach. It can be problematic with regard to nutrition, but it reduces the amount of glucose you absorb, and you get fuller faster to where you stop eating. Right? If you walk in after the surgery, if you had a giant thing of pasta like he would have, you just you can't literally fit it in your stomach anymore, and so you eat less, and so because you're eating less, you're consuming less glucose, and because you're consuming less glucose, you're shifting that equilibrium back to normal physiological range. For diabetics, and then obviously for obesity issues, consuming less calories is going to really result in. So it's a nice little mechanism. They are stupid expensive though. He spent a crap ton of money on that. Probably should have gone to Turkey.
Well, I know she did.
Who?
My hairstylist in New Orleans, she got it. She lost like a ton of weight.
Yeah. Uh-huh.
And I know that they can't eat like red meats right after, right?
Yeah, there's a whole bunch of like rules.
Mm-hmm.
There's a whole bunch of regular.
I know she was eating like vegetables and stuff, but they were like, I think like a whole year went by and she was like, I can't eat it. I don't think she was able to tolerate it.
Mm-hmm. Yeah, things definitely change.
Yeah.
And there's a whole bunch of regulatory weeds and stuff like that. But it can be a mechanism of some patients who just, I don't know how to word this. Like, I don't want to say lack discipline, but like hormonally can't control their appetite. How about that? In an unhealthy manner. And I'm not blaming them because I think it's more of a societal thing and these people are more victims than anything else. Yeah, it's a mechanism that can work, and yeah, it worked on. I think my friend lost like 100 pounds after he had the surgery. Some of it, he lost like 30 pounds just prepping for it because they tell you to stop eating like a month beforehand because they need to empty everything out. And so you have to go to like a strictly liquid diet, and then the liquid just contains protein pretty much. And so he lost like 30 pounds just prepping for the surgery. But
I wonder how much is it?
Oh, it was like, I think for him, and this was done like 5 years ago, so it's probably more expensive now. But it was like $25,000. Yeah, pretty penny. but it's either that or like dying of
Yeah.
diabetes or a heart attack or something. So it's kind of worth it in the end, but it's just yeah. So never underestimate the importance of diet and exercise. A loss of about 5 to 10% of your body weight improves insulin sensitivity, blood pressure, and cholesterol levels. Active lifestyles approach may just be as beneficial as improving health outcomes as structured exercise programs, right? So it's an important thing. Diabetes can be critically affect your body and patients' health, to where just encouraging this is just another point of evidence of encouraging healthy diet, exercising, and then you can shift. If you're pre-diabetic, you can shift it down. If you're diabetic, you can make it easier for your life. Or if you're neither one of those, but you can just prevent it, it'll have a prevention effect as well. So it's just a really nice thing to diet and exercise to prevent all of what we talked about today. But other than that, you got any other questions? That's it for this one. All right.